Okay, good. So some disclosures. I'll try not to talk too much as far as the text, as Richard said. But, devices that embolize and what's their incidence, these are all underreported, of course, except in the randomized controlled trials and some of the registries. But you can see here that primarily transcatheter heart valves, a lot of the embolizations that you'll see were the earlier versions of the SAPIEN valve. With the S3, the incidence seems to be pretty small, maybe 1 in 1,000, 1 in 500. Half of them go aortic, half of them embolize ventricular. Well, mitral valve in the ring, it's not that common unless you're treating incomplete bands. And then, of course, valve and MAC, we have that global registry that was published that showed that the embolization rate was fairly high. I'm not really including the Evolut valve in this because I think of those more as real migrations, not full-on embolizations. And in their randomized control trials, they said there was no, quote, embolization. They obviously can migrate, and I think the Lotus, although I have no experience with it personally, seems to be exceedingly rare because of the type of deployment there. For non-THVs, the vascular plugs, not uncommon. You've seen a couple already. I'll show you some more. And then for the other commonly used devices, again, embolization is pretty rare. So why would a device embolize? Well, one is there's operator error, we suck, and then there's poor planning, again, we suck, and there could be just bad luck, in which case we blame the patient, right? But in general, I would say that it can occur despite meticulous planning and technique, and we have to say that, and I think that's very true. So what are the risks? What are the causes? There's the substrate, so it could be device-specific, older Sapiens, for example. Could be just poor, or intraprocedural planning. The most obvious thing there in a TAVR is you can't get a good aortogram with good coplanar view, and there are anatomical things. So in the valvular embolization world, large annuli, small SCJs, a paucity of valve, calcium, maybe basal septal hypertrophy, pre-existing mitral valve prosthesis. There's a recent report of that by one of my former colleagues. Inadequate annular anchoring, and then MAC and the distribution of MAC could obviously play a role in valvular embolization. Non-valvular, similar anatomic things, large defects. Here, poor tissue integrity. We've all probably had experiences with ventricular septal ruptures and trying to treat those. Inadequate anchoring anatomy, like a very small aortic rim in an ASD situation, or an appendage morphology that's not suitable for most devices. And then what are the preventable things? I think in general, lack of device familiarity and procedural experience has to top the list. In the valvular device embolization world, undersizing, non-annular deployment, pacer miscapture or premature cessation of overdrive pacing has to be considered. I'm going to show you that. Inadequate retraction of the pusher can lead to ventricular embolization during the balloon expandable valves. Premature retraction of the delivery balloon can lead to aortic or atrial embolization, again for the balloon expandable valves, and then nose cone device interaction when you're retracting the system, and then non-valvular, inadequate push-pull testing maybe of a device, an occlusion device, and then dislodgement with multiple device implantations during PVL closure. I'm going to show you that. There are some retrieval devices. A lot of us are very familiar with on the panel on the left, A and C, gooseneck snares and end snares. And then there are non-snare devices, obviously off-label, like bioptomes, biopsy forceps. And then there's some things that outside of the cath lab realm that you find in other suites in the hospital, stone removal devices, various IR devices. Our pulmonologists use some stuff, I guess, in there. And then there are some EP devices. So other suites have to be visited sometimes to find non-snare devices. What are the keys to embolization management? For the smaller non-transcatheter heart valve devices, often the goal is going to be retrieval. For the larger THVs, it's going to depend. The way I look at it, if it's an aortic embolization, your plan may be to deploy the device, the valve in situ. When it's a ventricular embolization, though, I think you really got to think about having to go to the OR, and this is where you got to figure out you're going to have to buy somebody a cup of coffee to do you a favor to get out of this one. And then when the device goes atrial, I think that's worth a little bit of discussion. There's probably some room for discussion here, some cool cases that I'm going to show you. So some general rules: don't lose the wire, keep the wire coaxial, try to avoid any kind of inverting or tumbling of that in a cardiac chamber. Sometimes you're going to need to push or pull to keep this valve away from major side branches, from the outflow tract, the leaflets, the tricuspid or mitral apparatus. I'll show you some of that. And then try to get to a safe place to buy yourself some time and maybe even call a friend. So here are some case examples. Here's an example of what I would call a pacer problem. So this is an earlier case. You can see a very rapid deployment. We don't do that anymore. But if you focus on the pacer wire itself, it's clearly not pacing in a rapid rate or has dislodged. And because the balloon has not yet been deflated, the ventricle said, just get out of here. I'm going to kick you out of here. You got to, and that's what happened. That's just a pacer problem that I think we all these days have been pretty good at avoiding. And this is a case where, again, you're going to probably just deploy this somewhere in the aorta, in the arch, transverse or down to the abdomen. Here's the pusher problem. So I'm just going to show this. This is from a publication that came out in JACC in the Mayo group, where clearly they haven't brought the pusher back. So this proximal part of the balloon and the proximal part of the stent can't fully expand, and they averted this, fortunately, because they got some contact, annular contact, brought the balloon back, and were able to luckily deploy it in the annulus. So that was a reverted pusher problem. Here's a ventricular embolization that came from our group. This is a 90-year-old getting a Sapien XT26, circa 2013. So here's this deployment, again, much more rapid than we do now. Doesn't look perfect, but let's do an aortogram, see what we got here. Looks high. There's quite a bit of AI. It doesn't show up great here because this is a small little injection, but there's quite a bit of AI. But we know how to fix this, right? Just get me another valve. Put it in here, pin it in place, and we're all good. This is no big deal. We're pros at this. And so here's this thing going up. Yeah, right? So, yeah, missed again, man. So what does your perfusionist like to drink again? How do you like your coffee? So here's this is 2 XTs, one of which is just tumbling around in the ventricle there. This is an operative case in all likelihood. What about ventricular embolization during a TMVR? Here's a case that the Emory guys showed. This is post-Lampoon. They're doing a mitral valve and ring with an S323. And it looks pretty good here. You know, for people who've done this, you know, you want to be very ventricular here. Looks pretty okay, but as they put down this balloon, you can see that it's clearly not anchoring at the annulus, and that's a full-on embolization. And they did something, I think, fascinating. They did a separate transeptal puncture, and for bioptome, valve skirt capture and stabilization. Those are my words, but that's essentially what they did. So they went across and they took a bioptome and grabbed the proximal edge of this device at the skirt, pulled it back and sort of stabilized it against the ring. And then they went ahead and got a larger valve, a 29 now, and deployed this in a way that it pinned the original valve. And they released this bioptome from the skirt just as they're starting to get a little annular contact. And you can see that here. We're going to let go here, and let's give it that full push right there. Get a nice result. So that's a very kind of cool case. A lot of good thinking in the middle of that. What about atrial embolizations during a TMVR? I'm just going to show this super quick. This was presented by Guerrero, Wang, and O'Neill, where they had an atrial embolization during a TMVR during a valve and MAC case. And you can see on the left here that they are using an Amplatzer device to fix this valve up against the atrial septum by deploying both parts of that. So here's a case of ours, 75-year-old gal, just sick as can be, tremendous amount of paravalve leak due to dehiscence from a valve that was put in 1985. And she was obviously surgical turn down. See, Richard, we can make good pictures too. We got a lot of leak here and nice 3Ds here showing a decent sized leak. I made this hemolysis thing. It was really a lot of heart failure too. So we said this is right up in our wheelhouse, which is transeptal puncture, and we'll get across this and put a couple of plugs in. I could not cross it. So we aborted after a little bit, and we figured, let me just bring her back. I'll do a 5 French transapical. I won't even close this hole. It's just 5 French. I'll put a couple AVP4s in there, and we should be good. So here on the right-hand side, we're pushing and pulling. We have a sort of buddy wire just posterior to that one device. And then, like Goggin showed earlier, and I'm right around now, I want you to focus on this top purple, and you can see the device go down to the what the old timers call the Iliac graveyard, when they used to mount stents themselves on balloons. So we lost that AVP4. That's the last AVP4 I've tried to put in. I don't know. I should have learned from somebody else, but I learned from myself. So I put an AVP2 through this 5 French system. Good push-pull there on that. Looks pretty okay. We split this jet. There's still a lot of residual, but we wanted to regroup and come back and maybe put some VSD devices in there. And so at the end, put a rim catheter up and around where we had access and just snared this, chose a 7mm gooseneck to snare this and pull it into a catheter. Brought the patient back. This time I used a 7 French sheath in the apex and put an 8mm VSD device in there, and I have, which is posterior to the original device. And on the right-hand screen there, I have to recross to get to the other side, and that was pretty easy, and just got something anterior, and we're gonna put a separate device in there. So, you know, really? So on the left, you can see that there were 2 devices there, I swear. And in the big panel there, one of those dogs flew away again. So we put a 10mm device across. We actually got mild MR. There may be some cognitive dissonance there, but it looked better. And then we put a 6mm ductal occluder in the apex, because over 5 French, certainly I think that should be done. And then went around back to the graveyard, and this time ipsilateral with an 1830 end snare, and easily took that, what was that? It was an AVP2 out. Sometimes you need 2 retrieval devices. Here's an example of where they pulled back a septal occluder into the IVC with a bioptome, but couldn't get it into the sheath. So they used a snare, and maybe some combination of the bioptome and the snare together was able to provide enough force to pull that in. And I think on the right-hand slide here, this is a pretty neat thing where they felt that by snaring both ends of this occluder, they could elongate and then pull into the sheath. Again, Guggen mentioned these are very satisfying. These pictures are pretty satisfying. These are not my cases. And then sometimes you just can't retrieve this thing, and you really have to dislodge it from the anatomy and away for surgery. So here's an example of a Watchman device embolization into the mitral valve apparatus. Here she comes. And creates a lot of MR and actually shock. So they go ahead and then try to dislodge this out of the mitral valve apparatus, and it goes into the LVOT, and that causes cardiac arrest. So what they did here was they used 2 separate pigtails, antegrade and retrograde, and just sort of pushed them out of the LVT and pushed it out of the apparatus as they awaited surgery. So some final thoughts here. Device embolization is rare and often avoidable. When it does occur, a mix of operator, anatomic, and device-related factors often are at play. When device is embolized, maintaining wire and or gear position and maintaining your cool are imperative. Knowing when to push, pull, retrieve, or simply buy time for definitive therapy is key. And then having the tools, knowledge, and on-the-fly savvy can avert the disaster and lead to a save. Thank you.